Oh, I only got one left for me. Y'all share. Who took your sheet?
He was okay sharing, but then I told him, I said, I'm carrying it with me. He said, well, I need a copy of this.
Well, I could send it out to y'all too.
Yeah, if you would do that, that'd be great.
I need to start writing people's emails down. How you doing? Tired? What do you mean you tired? Oh, jeez. I've been up since 5 with the little baby crying. Don't forget to sign in to get credit. You're working over in Henderson, right? All right, well, thank y'all for coming. This has probably been the biggest group we've had so far, so I'm very impressed. I appreciate everybody coming out. This is going to be CNS injury. For EMTs and MRs, this falls underneath the trauma section of the national requirement, so this will knock this out for you. Got some C collars to kind of go over some of that, and the protocol that is the newer one. Not a lot of changes from the old one, but I figured it'd be good to go over since you guys are probably going to be one of the first to get on scene for motor vehicle accidents and such that the collar would be used. So we'll get started here. A little bit of A&P to start with. Do I expect you to know every bone in the skull? Probably not, but you should at least know some of the bigger ones. Ones such as the parietal bone, frontal bone, temporal, know your mandible, your maxilla, occipital bone as well. Just kind of know where those different are. This way, if somebody starts complaining of pain, you have a little bit of an idea of the different parts of the skull that could be broken or have injuries related to it. Different other little bit else A&P, you have your suturals, which is your special joints where the bones of the skull is connected. And then we all know from on the children's side, the fontanelles, that little bit of tissues there. As we get older, those come on in. Those kind of dissipate away, of course, but just having an idea where those are and how those joints form with the skull are important. Of course, we need to know about the brain itself. We know that when we have CNS injuries, this is where a lot of our problems come in. Your cerebellum, your brainstem, your cerebrum, kind of have an idea of what all those are related to. And we talk a little bit about stroke. I know Dr. Phillips touches a little bit on this, but there's a lot of new stuff coming out with stroke that's important to have an idea about this. It's related to the same type of thing with CNS injuries. Knowing your meninges, your parts of your brainstem there, your pons and your medulla, and then of course we'll talk a little bit about the spinal cord itself. So your cerebrum, this is your largest part of the brain there, responsible for a lot of your higher functions, and then you have different hemispheres, and you kind of see from the chart there of the different areas that we have of what it controls. So it's kind of important to have an idea of those things, not to know every single one because there's too many to always remember, but you end up having somebody who gets a CNS injury and you're able to kind of pick up that they're having a speech problem. You see where the speech is located, right? So if somebody's having a speech-related difficulty from CNS injury, it's more likely that they have probably a frontal lobe. And then you focus a lot of your assessment on that, so you'd be more high suspicion that there's probably some injury there. Maybe you see some bleeding, maybe you see a skull fracture, something like that, just to kind of help you narrow in with your assessment. Your cerebellum, responsible for posture, equilibrium, coordination. This has been a very big topic in stroke. There's been a lot more strokes happening in this area of the brain, especially with younger folks. They've been seeing a lot of 27, 28-year-old males walking into hospitals just complaining of nausea, vomiting, looking like they're drunk and they're dropping dead because they're having a stroke in the cerebellum and they're not picking up on it because, if a 27-year-old walked into the hospital with nausea, vomiting, and kind of was going around, what do you think that is? Yeah, exactly. So it's important to have an idea of, if there's an injury there. These will be on the stroke side, and even the injury, these will be the folks that are standing up just kind of wobbling around. So obviously you still want to have a high index suspicion. Don't just think that these folks are drinking. Do a good assessment on them. Your brain stem, you got your midbrain, your pons, and your medulla. This is mostly a lot of maintenance of vital functions. Not a lot of injuries happen here. It's more, of course, with the shifting of the brain itself, but this is still an important area because you can have injuries as well as infarcts when we talk about other injuries related to stroke in here with these. Problem with these is you're going to see so many different symptoms that you're not going to be able to pick up on this one. It's probably going to be very consistent. If you have a stroke in something like this is the type of patient that's going to have kind of equalized problems. So you may see that the person has multiple facial droop, multiple issues on both sides. It kind of throw you off because you're so used to seeing one side versus one side with these injuries. So if you see consistency, you should be very high index of suspicion that this is probably a brainstem injury with these types of folks. Your meninges, your protective layers, you got CSF fluid in there. You see in that little picture, you have a couple different ones that's important. Your dura mater, your arachnoid, and then your pitameter. Those are the different layers that you want to be have a little bit of knowledge of. The spine itself, 33 irregular bones with your vertebrae, 712, 554. Have an idea of kind of where they lay. Will help you with your injury and suspicion as far as if you had somebody who has an injury and now they're no longer breathing. So if somebody's no longer breathing, where do you think they're having a spinal cord injury? Just looking at that. Probably pretty high up. Probably talking about probably a C1, somewhere in that area range. Maybe down towards the lower part of the cervical collar area, or the cervical area. So just have an idea of those different ones and where those different positions are. Spinal cord itself, transference to nerves, impulses of the brain. If you look there, talks about your cervical for your diaphragm, and then you have your brachial plateau that controls your upper extremities, your lumbar down there, supplies the skin and muscles, the abdominal wall, and talks about your genitals as well as your lower limbs, and then your sacral. Talks a lot about your buttocks and more of the lower limbs. So if those injuries are injured, that's kind of where you're going to see your different signs and symptoms related to a spinal cord injury. We're going to talk about the difference between the two as well. Your sympathetic nervous system, this is the fight or flight response. Your hypothalamus controls this. This is where you get that sweaty pupil dilation, temperature regulation, your fight or flight like we just talked about just a second ago. And your parasympathetic is kind of the opposite of that. This is kind of what tells your organs what to do. Does a lot of your slowing your heart rate. Sympathetic nerves are stimulated. This is going to be your kind of your rest and your digest, the relaxing part of it. Probably most of what we see is going to be our sympathetic nervous system response. So a little bit of statistics. I'm a big fan of statistics. I think you have to prove things, EMS folks. So I always include lots of statistics and things when I do it. Causes, and I think we see this here in Person County. I think this is a pretty on the spot. I think falls may be a little higher in Person County, but it's pretty on the spot of what Person County's like. Vehicle collisions, 48%, falls, 21%, gunshot wounds, recreational activities. I may switch the two of those, but we do a ton of falls. I think the gravitational pull is different here. Like when you hit the Person County line, I'm not sure, but that's been one of our major focuses is trying to reduce those types of falls. But I think if everywhere you look, I'm part of the Duke RAC, which covers Durham, Wake, Orange County. Well, no, sorry, not Orange County, Caswell County, Granville, Vance, and these are everywhere. This is the number ones. Of course, some of them might be a little different, a little off, but we got a lot of elderly folks that live in our county, so, and we got always have some terrible wrecks. So your spinal column injury, and this is where we're going to tell the difference. This is when you have an injury to the vertebrae that surrounds the actual cord. So these would be the types of folks that have fractures, dislocations. These would be the folks that you have step downs. You have pain when you palpate on the actual vertebrae of the spine itself. These are the folks that are still able to move around. It's just an injury to the actual vertebrae. Whereas the cord itself, these are the folks that you'll come up to and say, I can't move my legs. And of course, what is always our instinct? Until we're like, oh, you really can't feel your legs. There's a problem. Then this is the actual cord itself is injured. What's worse? Probably the spinal cord injury, of course. Most of the time, that's not fixable. Usually, once you mess that up, it's a long road ahead at least. You have complete and you have incomplete spinal cord injury. So you're complete. You have transection, usually full loss of motor, sensory, autonomic function below. You can end up having what we call spinal shock. Same thing as shock, but of course it's just related to the spine. So neurological shock would be most likely what would happen with this. And then incomplete, there's a couple different ones. So one portion of the track or more than one portion of the track itself is actually injured. You see down the pictures down there of the different types that could happen. You can have some signs and symptoms. They can be very varied with these. These are the ones that'll get you in trouble because you start doing your assessment, you get good PMS, and then you have that one thing that just sticks out. You're like, oh, no big deal. These are the ones we need to work out for versus the complete where we know for sure that there's actually a cord injury. Central cord system, this is the middle portion of the motor and pain tracts that control the upper extremities. The lateral portion controls the lower extremities. We have an injury in that middle portion, and so we have these folks that have the weakness, they have paralysis going on, loss of sensation, mostly in our upper extremities. So these would be the folks that say, I got that pins and needles in my fingers and my hands, but everything below there is really okay. And then we have our anterior cords. We have a loss of function, but not in the light touch. So that's where we laugh at these when we were in EMT school, where they're doing these assessments and they're lightly touching folks, and they're like, oh, what's that going to tell you? It actually makes a difference based on what these different cords are. So, is it something that we need to be doing in the middle of a wreck scene? Probably not. When we get in the back of the ambulance or in a quiet area where we can really assess these folks, it's probably something that's important. You do a good assessment, everything seems to be fine. You got a chance to do a light touch, just taking a pen. Can you feel that? Something like that, it's just fine. Your Round-Sicard syndrome, this is injury affects only one side of the cord. So this may be kind of stroke-like symptoms where you have that one side of the cord. It's obviously not the opposite of stroke. So if there's an injury on that right side, they're going to have right side deficit. And then sometimes you'll have that pain on the opposite side itself. So you can see that different side there. So it might throw you off just a little bit. Do a good neurological exam. It's very important. Assess flexion, extension. I'm not going to read all these ones here, but it's important to really assess all the different movements that can be done with pulse motor sensory, moving hands, squeezing, light touch response, painful response, being able to move the wrist and hand in different ways, the feet in different ways. If you really ever get a chance to watch a neurologist do an exam, it is really awesome to watch because they do things that you're like, that's what a little kid would do, but it actually makes a difference. I always call it PMS. I've been told that that's not the proper terminology anymore. It's CMS, so it's circulatory motor sensory. I'm probably going to throw out PMS here and there, but assess that, please. Assess the neck. Do the step-down check. We want to look for any tenderness. Babinski reflex is another one that you can do. It's a plantar response. You see that that picture down there. This when the big toe does what the sole of the foot is simulated. The one you have to watch out for is little kids. If you get newborns up to 2 years old, you will get a false positive. So you have to really focus on this for kind of your, I guess it'd be your 5 years old, just to be safe and up. very much a sign of a CNS injury. So you'll actually get where you go from the bottom up, and you'll see that kind of that spreading of the toes, and you either have an absent or present finding, so it's pretty obvious whether or not you're going to get it. TBI, traumatic brain injury. You have a disruption of normal function in the brain. You have two main types there, concussion and a contusion. Concussion can be very mild, that you're very unaware of injuries, and then your contusion would be the coup or the counter coup. So this is where you get that kind of front or rear injury. This would be the folks that kind of have that sudden jolt, car accidents, get hit with a ball, something along those lines. Something that I included in this, and I can email out, and I'll have Chase put it up here when we're all done, but there's a huge focus on concussions when it comes to high school related to football and sports. They've actually changed a lot of laws. Person County's been up on those laws, so it's really good to definitely have that type of stuff being done, just because we just don't know if sometimes that folks are having concussions or not. You can have lacerations, hematomas, your subdural, which is under, your epidural is between, and then your intracerebral. So you see where those different ones are, and that's just where you have an injury and the blood is filling up within somewhere of those layers, and causing irritation or causing bruising. And you know, a lot of this will present very similar to a stroke, because that's what a lot of it is. Intracranial pressure. So you have a hematoma, you have that blood that is starting to really pool up in that section of the brain, pushing on the brain, and we know the brain is what? And the skull is what? It's a closed area, right? So there's not a lot of room for that blood to really go. There's not a lot of room for the brain to go. So as we continue to get that buildup of blood, the brain starts to become squished. The heart has to work harder. Blood pressure goes up. We get increase in intracranial pressure. And brain does not like that very much. Perfusion doesn't work out very well. Start getting these different neurological symptoms. And the one thing, like it says in bullet 3, it's all about time. It really depends on the injury. It also depends on the person. If they have pre-existing medical conditions, of how long that could take. So there's really no time frame on it. So things to look out for. Probably the biggest one to really watch, there's two big ones really, but the biggest one is AMS. If somebody starts becoming altered on you after they get hit in the head, that is probably the #1 sign that there is a problem, followed by vomiting. Somebody has that projectile vomiting, they have a head injury without a doubt, and they're altered. If you wait for Cushing's triad or Cushing's reflex there, the top one, where you have that blood pressure go real high and the heart rate go real low, you're what we call behind the 8 ball. Vital signs is probably one of the last things that's going to change. That altered mental status and the vomiting are the ones you need to look out for. If you get the decorticate or the decerebrate posturing, you are way behind the 8 ball. This is when things are at the point where this person's probably going to die. This is where you have that, everybody knows what the posturing is, right? Where you have the decorticate and decerebrate. I always remember the decorticate towards the core, and decerebrate where they have the real tight posturing and the rigidness out in the body, and then headache and seizures. These would be the types of folks that tell you these are the worst headaches ever. This is kind of like one of those aneurysm types effects, especially when it gets really, really severe. So these are things to look out for, but really focus on that altered mental status and the vomiting for your kind of your intracranial pressure stuff. Diffuse agonal injury, or the DAI, this is associated with or similar to your concussion. Usually have some type of stretching, shearing, tearing, some type of fiber tearing going on, mild, moderate, severe. And the way they differentiate this is based on the Advanced Trauma Life Support Guidelines. Somebody has a GCS between 13 and 15, mild, 9 to 12 is moderate, and then 3 to 8 would be severe. Care education for concussion patient. If you suspect somebody has it, take them to the hospital. Somewhere that has a CT scanner is the main focus. And at least, you know, if you get one of those folks that's in denial that they have one, at least get them somewhere they can do a CT on them. If it's somebody that you're really sure, they need to be going to a trauma center, need to be heading on their way to Duke. This way, if there is something, they can get immediate surgery and immediate care that they need, not be delayed. But if you get folks, patient, family that are very persistent, adamant that this guy, this girl, whoever, there's no injuries there, they refuse treatment, you need to make sure we're educating them on warning signs and symptoms, make sure they understand everything that's going on. And I tell everybody, if it comes to the point, throw that 4-letter word out there. Well, I guess it's a 3-letter word, what you tell them. You could die. You will be dead if you don't go to the hospital. You can fall asleep, not wake up. Sometimes that usually is the kicker to get people to realize, hey, I should probably go spend 4 hours, 5 hours to go get checked out and be okay. Different things to tell them. If somebody has one pupil larger than the other, drowsiness, that's one you should definitely focus on. Headache that gets worse, doesn't go away. Weakness, numbness, repeated vomiting, nausea. You see that's a repeat again. Slurred speech, convulsions, seizures, not difficulty recognizing people or places, increased confusion, and then the loss of consciousness. So a lot of those symptoms are repeated there. You know, the ones that you need to definitely reinforce with them and ensure they definitely understand that before you leave. Concussion in sports policies. This comes from the handout that I was telling you guys about, the 3 action steps for North Carolina law. I think, if I'm not mistaken, from that sheet, there was 47 states that have adopted this so far. There's a couple that are a little behind, but educating the coaches, parents, athletes, providing training, informational sessions, remove athlete from play, remove them from play right away. So if injury happens, they're done. They go to the sidelines and then obtain permission to return to play. So they have to be seen within 24 hours and be cleared by a healthcare provider before they're allowed to go back on. So this not only takes the coaches, but it takes the team and the parents to really enforce this, because you get the folks that are just in denial that anything's wrong and lets their kid go back onto the field, or coach lets them go back on the field, and that's where we have these issues and the injuries. So it's important to really focus on this. And as far as I know, that's the way things have been going. So it's great. All right, selective spinal protocol. As you know, Person County and most of North Carolina has pretty much removed backboards from their ambulances. We carry them still just for movement purposes. And for those that have been in this for a long while, back when this first started, EMS in general, backboards were only supposed to be for what? Moving a patient. And then somebody somewhere, I wish I could find out and go back and no, I'm not going to say that, but decided that we should put these patients on these things and that it was the best thing for them. And then finally, a few years ago, they've realized that they're actually more harmful. So the state came up with this awesome protocol. At first, paramedics were the only ones allowed to do it, and then we were able to convince them, hey, let's train everybody. Let's let everybody have the ability to do it, especially since in a lot of counties, you guys are the first on scene to come in contact with a lot of these patients. So now this is approved for EMT level and above. It's called selective spinal restriction. Spinal restriction is the key to this. We're not backboarding these folks, strapping them down to the stretcher and making it where they can't move. We are just trying to do our best to restrict their movement. And in most cases, that means putting on a collar, educating them, hey, I need you to stay as still as possible. You could have a spinal injury. I want you to be comfortable, but I want you to stay as still as you can and just have them relax on the stretcher. As far as movement goes, try to restrict their movement. That's the biggest point of this whole thing. Keeping their spine straight, keeping their neck straight, moving them out of the car with the backboard, and then taking them off the backboard, or using the scoop to move them, or gently having them move over, whatever is most comfortable for them without causing any further injury. And in most cases, the little tiny movements that we do are not going to make a difference. It's the really strenuous movements that we do. Usually, if you guys know, on backboards, we move people and jerk them all around, and we're probably causing more injuries than we're doing any good, but that's a whole nother conversation in itself. There's a acronym because North Carolina loves acronyms. It's called NSAIDs. And if you know what an NSAID is, it's an easy way to remember it. But column left over here, as long as you stay in the nose, you're good. The second you move to the yes, that's when you have to provide some type of spinal restriction for them. Now, does this mean because you get to the bottom and somebody finally meets the point where they're all nose that you don't have to put a collar on them? Does not mean anything like that. This is just to help you, guide you. If you have somebody that you're still really suspicious of, don't ever not put a collar on them. I'd rather you do it, be safe, than not. Your neuro exam, that's why I say you really got to do a good neuro exam. If they have any deficit, yes, you want to do the spinal restriction. If not, you move to the next one. S is significant mechanism of injury. Everybody's definition of a significant mechanism of injury is different. Some people would say falling down, little grandma that falls down right here is significant. And that could be significant for a little grandma. Now, if I failed, it might not be as significant. You know, that high mechanism of injury is really what you got to focus on. They give you some examples here. High energy ejection, high falls, eruption, deceleration, crashes. Yes or no? If yes, move over. Go ahead and do the spinal restriction. No, we keep going down the line. You'll see the A stands for alertness. So is this person fully alert? Do they have any altered mental status? If they do, yes, you're going to do the spinal restriction. If not, you can move down the line. I is intoxication. This one gets everybody. Somebody's intoxicated, they need to be collared. If not, you move down. Does intoxication only mean alcohol? No. You see it on there. It says drugs and alcohol. Distracting injury. Everybody's definition of a distracting injury is different. To me, a hand falling off, you know, big broken bone, they're walking around like, yeah, I'm good. No, you're not. That's a distracting injury. The body and the brain are only really able to focus on one main point. So if they're focused on an injury here that hurts really, really bad, they're not going to know that they have a C1 fracture or whatever the case may be. So if they have a distracting injury, you feel it's really distracting to them, even if it's something as minor as a cut that's bleeding really bad and they don't like blood, that's a distracting injury. They may focus all of their attention on that. So if it's a yes, move over. If no, keep going down. And lastly, you're going to do a spinal exam where you're going to go down the spine, feel down the spine, see if they have any tenderness, and ask them if they have any pain when I'm going down, just tell me to stop. Or if you feel any step downs, anything that feels irregular to you, yes, move over. No, you'll see what it says down at the bottom. Spinal restriction is not required. Yes, you see over on the sign, apply a cervical mobilization device, restrict movement, and then follow your protocols based on that. And you see that in really big letters, it says use a long spinal board or any multiple devices to transfer a patient, not keep them on it. Want to get them off of it. It hurts. It's a pain. We know these patients don't want to be on it. If anybody's ever been on it, you know what it's like. It's terrible. So I'm glad that we're able to move forward in EMS and do what's best for these patients, especially little kids. Has anybody ever put a little kid in one of those devices? They just fight you. And then, you know, they're fighting you and they're like, well, if you have a spinal injury, I just made it worse. So it's important to really, I think this is really good that we've moved this way and the state has moved this way altogether. So I could not find a helmet. Unfortunately, I sold my motorcycle and I forgot to ask Brandon if I could borrow his today. So it just slipped my mind. But we get a lot of these. I think it's important that I know Chris Reagan's working with the athletic director of trying to get the state. They had this really cool, I got to get back with Michelle with it, but they had this really big thing where they were pushing out education for helmets and removing helmets. And so I'd like to hopefully eventually get something where we're able to go over there, film something, I can throw it online for everybody to see to kind of get the best practices of what they feel. From what Chris has told me so far is as long as there's nothing that's obstructing here, they want you to leave the helmet on as far as the football side goes. And that can be the same thing when we're talking about injuries related to a motorcycle. If, you know, that rider is able to keep their head stable, they're not having any airway issues and you're not worried about it, you can keep it on. You know, that's not a big deal. Just, you know, explain why you're doing that, especially when paramedics get there. This way, everybody's in the same agreement and boat. And but if you have to get it off, You're definitely going to need 2 people to do it. I'm sure you all have done this before. Just a quick little refresher on it. Got one person that's going to hold the helmet. Next person's going to undo the buckle. Make sure you know how to undo the buckle or cut it. Either way, the helmet's going to hopefully go in the garbage. Hopefully nobody re-wears it. Second person is going to come in. They're going to hold the head up. Remember, the head's going to be a little elevated, so that's where the main focus of that second person is going to be in. Gently wiggle back and forth. As that helmet starts to come off, that second person is going to move their hand up, still holding the chin in as best inline position as possible, but being able to support the head. And as it comes, supporting that head this way, when he removes that little bit of the helmet, there's no drop in the head itself. And then gently move down the head to a neutral position. You can apply your C-collar. Y'all remember how to properly put on a C-collar? Or is everybody a no-neck? You'd be surprised. Well, I'll talk about that in a second. But I remember had just joined the volunteer squad back home, and that was like what everybody told. Everybody's no neck. We don't carry anything but no necks. I'm like, no, that's not the case. You put a no neck on, and I'm like this. You put it on when it's properly, and it doesn't hurt. And I think that's why a lot of people hate these things, because they don't put them on properly. But technically, what you're supposed to do is measure. So the side of your head, measure with your fingers. And then estimate it with that. Very rarely is there anybody with a no neck. And the cool thing about our collars is they're adjustable, so you can move them around. Don't have to worry about carrying 5 million different collars. So you fill it up, able to measure it. And this one, they have multiple collars as far as sizes go. So they're going to have to figure that out, whereas we can measure it, move up the little things, lock them in place. Please don't forget that in the collar, this comes up. I love watching people do this. I can't get it to go on. You got to lift this little flap up. And then there's your adjustment for that. And now's a little time here. I figure we take a few minutes, talk about some changes that we've made, and then if everybody wants to practice putting the collar on. And that'll be it for the evening. Anybody got any questions? Before I forget, real quick, in, I think it was October, but I really need to make sure of that first. I'm fairly certain we are going out to Allensville. We have an OB lecture coming up with that. And we just purchased a couple new mannequins, and one of the mannequins we just purchased is an OB mannequin that births the baby by itself. So I'm really excited to get that out and get that training done. I'm debating on whether or not I want y'all to dress up in really crappy clothes and me go get fake blood and all that stuff and really make it realistic, but I'm excited to have a mannequin that you try to make it a little more simulated realistic stuff, because who knows, maybe one day you'll get to. Huh? I knew it was coming up. I just couldn't remember when it was. So I'll make sure I get that date properly. I know it's in my phone somewhere. I just couldn't find it earlier, but hope y'all can come and join us. That should be a good time.